Thank you, Max. Especially thank you for invitation. So my topic are the male slings. Finally, about 10% of the patients end up with persistent stress incontinence after prostate surgery. And as you already heard, the incontinence has a major impact on quality of life, physical activity, and social well-being. So today we have several surgical treatment options available, including the artificial sphincter and several sling systems, the fixed uterine slings, and adjustable sling types. So when is surgical treatment recommended? After a period of conservative management, meaning physiotherapy of at least 6 months with a stable continence status. Max already mentioned it. I think it's really important if a patient is still improving with his incontinence, we shouldn't put in any implant. And of course, on patient's demand, if the patient is happy like this patient with his incontinence, there's no need for surgical treatment. So I had a look into the ICI recommendations. What does they tell us about male slings? And male slings are an alternative approach with intermediate data supporting the safety and efficacy in men with moderate degrees of post-prostatectomy incontinence. The only problem is nobody talks about different sling types in the recommendation. So first of all, why men prefer slings? So it's no mechanical device like the artificial sphincter, no difficult handling. It allows physiological voiding. It's maybe a smaller implant. I think it depends on the sling system. It's less invasive for some patients. We have no deactivation period. These are all reasons men prefer the slings. So the most commonly used sling systems are the Argus or the Argus T, the Atoms, the Remix, all adjustable systems, and the so-called fixed retrourethral slings. And this is the Advance or the second generation called the Advance XP. There are some new sling systems out in the market, like the Virtue system. It's also a fixed system with 4 arms. One of the 2 arms are pubic arms. You can see it here in the picture. And we have the I-stop Toms, also a fixed sling that is implanted only via a transobturatoric approach. So I would like to go first into the fixed uretral slings, the Advance and the Advance XP sling. You can here see the Advance slings. The Advance slings, for example, is available in the US. The XP, this is the second generation, is now available in Europe. The XP has no FDA approval at the moment, and so therefore not available in the US. You can see one important difference between the first and the second generation are these anchors here to stabilize the system in the early post-op period. So it's always a discussion, what is the mode of action of the Advance sling? I think it's really multifactorial. It's not only one reason. And if you remember back the pathophysiology in Flavio's talk, then the Advance addresses a lot of problems after radical prostatectomy. So the Advance should stabilize the post-op hypermobility of the urethra, should increase the length of the functional urethra, and improve the venous sealing effect. What's the outcome of the Advance sling? I combined here every study we have already available. We have a maximum follow-up published of up to 3 years with a cure rate of up to 73%. We know that after radiotherapy, the success rate is lower, and we know that the complications rate of the advanced sling are really low. The main problem is temporary residual urine after the implantation, but with the advanced sling, this was never a problem because it resolved by itself. Problems like persistent pain, infection, and explantation is not really an issue with the advanced or the advanced P. But we have a problem with the advanced XP. This is overtensioning. The reason is these nice anchors. It was a really good idea to fix the sling in the early post-op period so the patient is able to be more active after surgery. But when you overtension the system, then there's no relief of the system and the patient stays with his residual urine. And this is not temporary, this is persistent. So it's really important that you avoid overtensioning during implantation. And one of the reasons why you do an overtensioning during implantation can be these plastic sheets around the SLINGS arm. Sometimes it's really difficult to take it out, and if you really need a lot of strength to take it out, then you can overtension it. So this is why I recommend to fix the SLINGS arms while pulling out the plastic sheets. So what can you do when you have the overtensioning problem and the persistent residual urine? In Munich, we wait for 3 months. We wait the healing period, we wait that everything is stabilized, and then we cut only one sling arm directly at the bone. And the clue is that in the majority of the cases, the urethra is still stabilized, but you have again a little bit mobility that the man needs to start the micturition process. So the majority of the patients we treated with only cutting one sling arms are still continent. If you cut both slings arms, they are incontinent again, like they were before. In contrast, the mode of action for the adjustable sling systems is completely different to the advanced sling. In the adjustable sling systems, you increase permanently the ureteral resistance to support the basis continence. You remember the pathophysiology talk earlier this morning. What are the outcome of the adjustable slings? So I put everything together, the Argus, the Atoms, and the Remix, all studies we have. You can see we have some cases really long follow-ups. If you have a look at the outcome of all the adjustable sling systems are comparable. The only difference you have are the complications. So you have different explantation rate, different pain problems after implantation, different adjustment rates, and the invasivity for the adjustment itself is different. So for the Atoms, you only need a needle and you have a nice port to adjust. For the Argus, very often you need really an anesthesia to adjust the patient. So now the question is, does one fit all patients? This is our German chancellor, so for her the trousers are always perfect, for the other guys not really. So now the question is how to choose the right system for the perfect system for each patient. You can have a look at the continence rate and the complications and choose the system you like the most. You can look what's your preference, what system do you implant, what's your preference, or you can do a patient selection. When we look at the adjustable systems, in my opinion, the outcome and the surgeon's preference is the way how to choose the system, because you saw the complications are really the outcome is really comparable. You have some differences with the complication, so outcome and surgeon's preference is a good thing to choose. But if you have to choose between adjustable, or if you want to choose between adjustable and fixed slings, then the story is not so easy. You need a better patient selection. And how can you select the patient for an adjustable or a fixed sling? Which one is the perfect patient for a fixed sling? Therefore, we use the ureteroscopy. So first of all, we can rule out any anastomosis strictures, have a look at the atrophy, elasticity of the uterus, especially after radiotherapy. Then I can have a look at the sphincter function. Is there a sphincter defect? And for me, very important, how was the physiotherapy? Is the patient really doing a pelvic floor training? And not only a training of the abdominal muscles or the gluteal muscles. So if I find out that the patient never trained the correct muscle during the pelvic floor training, then I send the patient back to a physiotherapist. And in these cases, I really have a list. There's a very good list online in Germany for specially educated physiotherapists, and I sent back the patient to one of these physiotherapists. Because in Germany, every physiotherapist is allowed to teach the patient's pelvic floor training. And this ends up very often with bad results. If the patient is able to use the pelvic floor to contract the sphincter, I perform the repositioning test to evaluate the residual sphincter function. Who of you is doing the repositioning test, or some colleagues call it GOTSI test? Nobody? Then I will show you how it works. So I need a cystoscope, of course. I'm distally of the sphincter. I put some mild, really mild, not in heavy force, only mild pressure mid-perineal, parallel to the anal canal and below the urethra. Not going up, not going down. And during this maneuver, I reposition the posterior urethra. If the test is positive at this moment, the sphincter contracts completely without any help of the patient. So you can see, you can use a sponge, or I use very often the fingers. It doesn't matter. The only important thing is that you use only mild pressure and parallel pressure. And then when I closed the sphincter by my repositioning, then I ask the patient to contract the sphincter, the pelvic floor. And this is the second important point of the repositioning test. At this moment, if the test is positive and the patient contracts the pelvic floor and the sphincter, the so-called cooperative zone, the functional sphincter, contracts, and you can see I'm here and here in the same position, and all this is the cooperative zone of the sphincter, and it closes when the patient actively contracts the sphincter. And this here should at least 1 centimeter. And only patients with a positive repositioning test show the best results with the advanced sling. Of course, you can put the advance in every patient. This is what we did in the early beginning of the advanced sling. But we saw a lot of failures. So this is the repositioning, once again, the movie. So this is only the repositioning, that's me. And now this was the patient, the active sphincter contraction. Once again, this is the repositioning of the sphincter, concentric closure, And now the patient closes the sphincter actively, and you can measure the cooperative zone. These are patients with a negative test. And I can tell you, these patients had all an advanced sling later on, and all of these patients were failure. It was in the very early beginning. So today, I wouldn't implant an advanced sling in these patients. This is a patient after radical prostatectomy. He had a radiotherapy, and he had several anastomosis strictures and resection. And I have only a look at the sphincter. Then this looked like a sphincter defect. I can see it during the repositioning. It closes, but not completely. And the cooperative zone is almost zero. Nothing closes here. So he had an advanced sling, he was a failure, and he had later on an artificial sphincter. The good thing is with the advanced sling, you don't have to take it out. You can only put in an artificial sphincter, and it doesn't interfere with the advance. But in my opinion, we should choose the perfect surgery and not do reduce. So this is a second patient. He also had a advanced sling, and he failed. He had he had no radical prostatectomy. He had a TOP. You can see here must be a sphincter defect. During the repositioning of the sphincter, you see really perfectly the sphincter defect. During the active sphincter contraction, the sphincter defect closes, but the cooperative zone is almost zero. So don't put in an advanced sling in this patient. This will end up with a very unhappy patient. So the preconditions for success are for the fixed slings, especially for the advanced sling, because with the advanced sling, there's worldwide the highest experience. The cooperative zone, the functional sphincter, should be at least 1 centimeter. The posterior ureter should be mobile, not fixed. The patient shouldn't have been a radiotherapy. And the risk factors for failure is a weak sphincter function, a sphincter defect, and an incomplete sphincter closure. The adjustable sling system, in contrast, the functional sphincter length is not important. The patient needs a residual sphincter function and shouldn't be complete incontinent, because these patients doesn't really work well with the adjustable slings. So in conclusion, if we want to treat our patients individually, we need several implantation techniques, several sling systems, and of course the artificial sphincter. Erwin will give us later on a talk about the artificial sphincter. These are the important factors of the patients for the individual treatment. Thank you very much.
Thank you so much, Ricarda. I think it is important that if people talk about slings, and both fixed and adjustable slings, that it's should be people who really use both of them and have some experience with both methods. Are there questions out there? There must be questions. Feel free. In this moment, feel free to what you ever wanted to know about slings.
Great presentation. In our patients, we only perform the contraction maneuver. We don't pull the muscles. Do you think
we did it in the early beginning, the same, and then we figured out that there's a better patient selection if we look at the cooperative zone. This is why we did a study on the cooperative zone. We implanted in patients with a short cooperative zone with a cooperative zone of more than 1 centimeter. And we saw that the results in the patients with the long cooperative zone, more than 1 centimeter, are the best.
Yes, but in your opinion, is there a difference if you pull the muscles or only ask to contract? Is there a difference in visual?
There's a difference.
Okay.
And if you ask the patient, then the patient tells you after the repositioning, I feel that the muscle is more strong now.
Okay.
Yeah.
Okay.
May I put the question to you? Are you also using adjustable slings?
No, I think
this is why you don't do this division between the two. But if you have both in your repertoire, you want to find the perfect patient for the advance. You might be happy in a way even using the fixed sling in your setting, but if you have an adjustable sling in your repertoire, you might want to split your patients even to have an optimal result.
Okay.
And that's why we tend to do this. And I think it's also important to know that if you do the repositioning test, you should not only see that the urethra closes, because that could be a mistake if you just push the urethra. Of course it is closed, but it should really concentrically close. You see that a sphincter is doing something. It's not just you're pushing with your finger or whatever.
If you push upwards, then you see there's coming up something from the lower part of the urethra, but it completely looks different.
Yeah.
It has really concentric, and you see the difference. You can do it once going upwards, and then you see what is the difference.
It's more locally.
Yeah.
No? Okay, perfect. And one other question. You didn't talk about this, but in your papers and other ones, the control of the adjustment, it's only 3-4 centimeters move the urethra forward.
With the advanced sling?
To the advanced sling, yes. And I saw in your papers you don't use the pressure.
No.
We don't use to. Do you agree it's unnecessary? Do you believe in these tests?
With the advanced, I agree in parts. So we, in the early beginning, we tried to pull as hard as we can with the advance. And we started the same with the advanced XP, and it ended up with permanent residual urine. And this is why we changed it a little bit. At the moment, we do a cystoscopy during the tensioning, and we stop it as soon as the sphincter is completely closed. Normally, you can pull more, but we stop at this moment. And after we changed it, we never saw again the retention problems. And the second important issue is to fix the sling arms during removal of these plastic sheets.
Of course, thank you.
But retrograde leak point pressure measurement is not necessary. Yeah.
When you're choosing the proper patient for adjustable sling, do you consider the bladder functions such as flow rate and residual urine?
I consider the flow rate.
Yeah, flow rate and residual urine. When you are choosing the proper patient for male sling.
So the flow rate is important for me to exclude an obstruction. So to have a first thought that maybe there's an obstruction.
I mean, many patients have some decreased flow rate and some amount of residual urine.
So if the patient has an obstruction, then I wouldn't do implant any kind of sling system or artificial sphincter. I would deobstruct the patient first. But very often the patient has an increased flow because of an increased urine volume. And in these cases, I do a urodynamic, and then I can rule out the obstruction. If the patient is not obstructed...
I mean, not only the obstruction, but also the bladder, underactive bladder patient. Underactive bladder patients. In underactive bladder patients, do you perform...
underactive. You mean underactive?
Patient, yeah. If the flow is not okay, I do a urodynamic, and then I can see if the bladder is underactive. But my experience is, so I put in an advanced sling, of course, because my experience is that very often, in many cases, the underactivity of the detrusor recovers after the incontinence treatment. So the underactivity of the detrusor is caused by in many cases by the incontinence. So it's not a reason for me to say this patient, you can't have an advanced sling.
After the placement of the adjustable sling, do you usually see the cystoscopy afterwards? So how the sphincter look like? So just closed or?
After the advanced sling,
yeah.
the sphincter is more closed.
Is it completely closed?
It depends on the patient and how relaxed is the patient, but the difference is before and after sling implantation, that before when the patient is incontinent, you see everything is open, wide open. And after the advanced sling implantation, it looks more like a patient before radical prostatectomy. When there's some sphincter contraction, you have to open a little bit the sphincter.
But in my experience, if I want to close the sphincter, I have to give a lot of pressure to the more tension, giving more tension. So then afterwards, the patient cannot void.
The patient can't void only when you had an overtensioning and the patient has no chance to lower down the posterior urethra during the micturition maneuver. The interesting part in these patients, if you do a ureteroscopy, you don't see really a compression or an obstruction, and you can see it very good during ultrasound.
Can I just say something
Yes.
about the compression? I think that the position of the sling in the urethra is very important. If you're
Of course.
not proximal enough, you may have to compress more to obtain this. So maybe you should reconsider where are you entering or exiting with your sling if you're doing a transoperative.
You have to dissect the centrum tendinium and really go below the centrum tendinium.
When you are doing the Argus sling, you dissect the central tendon also?
Excuse me. Maybe this is something for the break. We have to give other colleagues the chance. This may be something for the break.
May I just ask, despite very careful
And may I remind you of telling your name?
My name is Mr. Jain. I am from UK. My question is, despite very, very careful selection of your patients, the cure rate is not 100% with either sling or the adjustable device, which is supposed to be adjustable. Can you tell me the reasons for the failure?
So we have no 100% continence rate in the artificial sphincter even. So we have no 100% continence rate. And in my patient, if they ask me for 100% continence rate, I recommend a penis clamp. This is the only treatment, for me it's not a treatment, but this is the only treatment we can achieve 100% continence. What is the reason? I think the perfect system is not available at the moment. And the second is there are still some pathophysiologist problems we didn't understand until now, and we are not able to treat every problem with one system at the moment.
So do you tell your patients the option of artificial urinary sphincter as well as the other thing at the same time?
Yeah, of course. Okay. But I tell also the patient that there's no 100% cure rate. And typically in Germany, a lot of patients come to the office and tell us, we want to have a sling and no artificial sphincter, because an artificial sphincter is really dangerous. We have a lot of infection, a lot of problems, and my urologist told me never accept an artificial sphincter.
We are working on getting this generation who say this apart and away. So please go out there and let the people know that all these options are good options, and the AUS is not something incredibly invasive and dangerous, and we have to get rid of this idea.